Good evening, everyone. Today, our topic of discussion will be on the most important topic, hypertension, and the subsequent topic will be disease of aorta. So, we will deal about hypertension, its etiology, pathogenesis, and further management. And further about aorta. In aorta, we will discuss about both aortic aneurysms and aortic dissections. Okay, we'll start with hypertension. So, everyone knows, it is most common disease, and it doubles the risk of cardiovascular disease. It increases the risk of heart failure. It increases ischemic stroke, hemorrhagic stroke, renal failure, and peripheral artery disease. And even it affects eyes, causing hypertensive retinopathy. So, according to the Indian statistics, 33% of the urban population and 1/4 of rural population are hypertensive. In this, of this, only 25% rural and 42% urban Indians are aware of their hypertensive status. Even who are aware are not being correctly treated for hypertension. So that such is a pathologic situation of hypertension in India. So most common about this primary hypertension, essential hypertension, the most important risk factor is obesity. So obesity and weight gain are the independent risk factors for hypertension. So even 1 kilogram reduce in weight reduces the blood pressure by 1 millimeter of mercury. So other risk factors are due to the social stress, low levels of physical activity, and alcohol consumption. Okay, these are the mechanisms of hypertension. So the most important mechanisms are intravascular volume, autonomic nervous system, and renin-angiotensin system. So first is the intravascular volume. So intravascular volume, mainly the kidney plays an important role. The kidney is both a target and it's a cause of hypertension. So in patients of CKD, most of the patients will be having hypertension. So this is a cause of hypertension. So in what is the mechanism is, so mainly in the intravascular volume is due to the kidney disease, there will be diminished capacity to excrete sodium. So, and second thing, renin is secreted by the afferent arteriole. So, excess renin secretion, which causes excessive angiotensin and causes hypertension. Then, sympathetic nervous system overactivity. So, what happens in early stages when there is increased sodium chloride intake, the kidney compensates and it tries to excrete sodium. So, what happens? It increases the cardiac output initially. Further, as the process takes over, the cardiac output will come to normal and peripheral resistance increases. So this is the main pathogenesis of our hypertension. So another thing is, as there is a natural mechanism which is pressure natriuresis. As the BP keeps on increasing, the kidney compensates by excreting the sodium outside along with water. So at a point, the pressure natriuresis is impaired. So there will be inability to secrete sodium and water into the kidney. So at the time, the hypertension ensues. Next important is autonomic nervous system. So we know all this. Autonomic nervous system, it modulates blood pressure over the short term and also in the long term. So there are receptors, alpha 1 receptors, alpha and beta. In this, alpha 1, alpha 2 is there. So alpha 1 receptors are mainly, it is located on the postsynaptic cells. So they are vasoconstrictive. But alpha 2 receptors are located in the presynaptic cells. So that synthesis epinephrine. What happens? This is the presynaptic membrane. Then here the alpha 2 receptors will be located. So whenever you give alpha 2 agonist, it inhibits the synthesis of norepinephrine. It inhibits the synthesis of norepinephrine into the postsynaptic membrane. Thereby it decreases the blood pressure. So this is the alpha 2 agonist. Common drug which we use alpha 2 agonist is clonidine. Next it's myocardial. Next is beta 1 and beta 2. So everyone knows about the beta 1 receptors, which stimulates the rate and strength of cardiac contraction and increases cardiac output. Another thing is the beta 1 receptor is main important in kidney. It stimulates the renin release from the kidney. Next, beta 2 receptors, it relaxes vascular smooth muscle relaxation and results in vasodilatation. So coming to the first question, all are the stimuli for renin release except. So the answer for this question is all are stimuli for renin release. Decreased sodium chloride transport, in the distal portion will cause is basically what all causes hypotension will causes the renin to stimulate. So there is decreased sodium chloride transport that will stimulate the renin release, and this is decreased pressure or stretch within the renal afferent arterioles. This will also cause the renin release. Another one we previously discussed, sympathetic nervous system stimulate renin release. So the answer for this question is increased sodium chloride transport actually will inhibit the renin release. So these are the primary stimuli for the renin secretion. We already discussed, which is decreased sodium chloride transport, then decreased pressure and sympathetic nervous system activation. Coming to the main angiotensin aldosterone system, you all know this is the angiotensin which is acted upon by the renin converted to angiotensin 1. So it is a 10 peptide. Then angiotensin 1 is converted into angiotensin 2 by angiotensin converting enzyme. In this, there are angiotensin 2 acts on 2 receptors, angiotensin 1 receptor and angiotensin 2 receptor. Actually, angiotensin 2 receptor is very good receptor. Angiotensin 2 receptor, it induces vasodilatation. It causes sodium excretion and inhibition of cell growth and matrix formation. But whereas angiotensin 1 does all effects of angiotensin 2. So whenever we block the angiotensin 1 receptor with AR base, so it is the other pathway, the alternate pathway, it acts on angiotensin 2, and all these good effects, which is vasodilation, sodium excretion, and inhibition of cell growth occurs. So this is the benefit of ARBs. So then angiotensin 1 is converted into angiotensin 2 by AC. So this we have many drugs called AC inhibitors, which is first line drugs in heart failure and hypertension. So what happens next as we move on further? What are the consequences of hypertension? So what happens? The hypertension has effects on all the systems. So first, what happens? It is a direct cause for coronary artery disease. Next, it can cause congestive cardiac failure. First is diastolic failure. If you, as we already discussed about the heart failure with preserved ejection fraction, the most common risk factor is obesity, hypertension, and atrial fibrillation. So even hypertension is an independent risk factor for. So in the heart, it causes coronary artery disease, diastolic dysfunction, and finally systolic dysfunction and atrial fibrillation. So in brain it causes stroke. It causes both ischemic stroke and hemorrhagic stroke. Most commonly is ischemic stroke, and hypertension is independently associated with cognitive impairment. So treating improves dementia in some patients, vascular dementia, called as Binswanger's disease. Then once the patient is having very high BP due to the autoregulation, there will be increased blood flow to the brain, and it causes hypertensive encephalopathy, which leads to the altered sensorium coma and seizures. So this is due to the failure of the autoregulation. Next, it can also affect the kidney, causing albuminuria and hypertensive glomerulosclerosis, and it causes finally CKD. So it also affects the peripheral arteries also. So leading to the atherosclerosis of the arteries, and it leads to the peripheral artery disease. Whenever the ankle brachial pressure index is less than 0.9, it is the peripheral artery disease. Okay. So next we will discuss what is the definition of hypertension. We will discuss only ESC criteria, which is you can read both ESC and ACC, but due to lack of time, we will discuss only ESC criteria. So this is the European Society of Cardiology 2018 criteria. In this, there is 6 readings. Primarily, we tell the BP whenever it is hypertension, whenever the BP is more than 140. So before that, it is called as high normal, and normal BP is 120 to 129. So the hypertension in according to ACC it's 130. According to the ESC it is 140. More than 140 is hypertension. So in this, the grade 1, grade 2, grade 3. Then optimal BP is 120/80, normal BP is 120 to 129, 80 to 84. High normal is 130 to 139 and 85 to 89. And above 140/90 is hypertension, it grading on grade 1, grade 2, grade 3. So this is the ESC 2018 classification of hypertension. This you have to know. Then coming to the next very important point is this very masked hypertension and white coat hypertension. So white coat hypertension everyone knows. So the patient, when comes to the office or hospital, patient will having high BP in. So high BP in hospital, then the patient will have normal BP at home. So this is okay, normal BP at home. But the most dangerous thing is this is masked hypertension. Whenever the patient is coming to the hospital, the patient hospital BP will be normal. But in home, the patient BP is high. So this we miss often when we check the office blood pressure measurements. Or so this can be overcome by ambulatory blood pressure monitoring. So masked hypertension is very important to diagnose because it is associated with very high risk of cardiovascular events and coronary artery disease. White coat hypertension, even if it is diagnosed in hospital, no need to worry. It has same risk as the patient who is having normotensive, but masked hypertension has high risk of coronary vascular diseases. So this can be diagnosed by ambulatory blood pressure monitoring, which is average blood pressure they measure over 24 hours, which can be measured, which measures once in half an hour, and it gives average BP reading, both daytime reading, nighttime reading, and average 24 hours ABPM. So another important concept is dipping. So nighttime blood pressures are generally 10 to 20% lower than daytime blood pressures. This is called dipping. This is normal. This is physiological. So whenever there is no dipping, it is associated with increased cardiovascular risk. So ABPM is very essential in identifying the masked hypertension. And another important thing, it identifies whether the patient is not physiological, not associated with increased cardiovascular. Common we essential primary hypertension. Actually, due to the idiopathic, when all other secondary causes are ruled out, then it is essential hypertension, and it's the most common cause of hypertension. It can be due to obesity, obstructive sleep apnea, high salt intake, low potassium intake. So this called as essential hypertension. So next we will discuss about secondary hypertension. Secondary hypertension, there is a particular cause for the disease. So coming to the second question, what is the commonest cause of secondary hypertension? Pheochromocytoma, Cushing, hypothyroidism, and primary aldosteronism. Okay. Most of them are answered Cushing, but the answer for this question is primary hyperaldosteronism. The most common cause of secondary hypertension is actually renal causes. So, but the option is renal is not there. So, second most common is primary hyperaldosteronism, which we don't diagnose. We think that only hypertension and hypokalemia should be present. Hypertension and hypokalemia, at that time we suspect patient of primary hyperaldosteronism, but the hypokalemia in primary hyperaldosteronism is present in only 34% of patients. Even normokalemia with hypertension, if the patient is having secondary hypertension, we should suspect primary hyperaldosteronism. So the commonest, actually, this endocrine cause is primary hyperaldosteronism. Okay, sir. Next question, all of the drugs causes hypertension except. Very good. Most of you answered correctly. Very good. So all these drugs will cause hypertension. Tricyclic antidepressant, atypical antipsychotics, and cocaine. But pentamidine, it is a drug which is used in, it's antibiotic which causes profound hypotension and arrhythmias. It is used in the treatment of pneumocystis carinii pneumonia. So the answer for this question is pentamidine. So we'll discuss that further. So this is the cause of secondary hypertension. This start from Harrison. First is renal cause. So we know all the main cause is CKD, which is a parenchymal disease. Parenchymal disease is CKD. Next is PKD or ARPKD, which is a polycystic disease. Second is renin secreting tumors. The renin secreting tumors like hemangiopericytoma, So next is obstructive uropathy. These are all the renal causes, renal parenchymal causes of hypertension. Second, the most common we have to suspect about renal. Only we have to auscultate the patient for renal artery bruit. It can be things. When it occurs in young patient, we have to suspect about young patient fibromuscular dysplasia. When it is in old, it is due to normal atherosclerosis. Next, very most missing adrenals. And adrenals, there are three things are there. Hyperaldosteronism. So in adrenals, hyperaldosteronism is the most common. Second is Cushing syndrome. And third is pheochromocytoma. So all these are adrenal cause, most important adrenal cause of hypertension. Next is most common congenital cardiovascular causes coarctation of aorta. We'll discuss this in subsequent slides. Next, obstructive sleep apnea. So obstructive sleep apnea, we mostly neglect this cause. Any obese patient, we have to ask for snoring history from the attenders, and we have to see for apnea hypopnea index. Next, any preeclampsia or eclampsia, the high risk of hypertension. Next, you can miscellaneous causes like hypothyroidism, hyperthyroidism, hypercalcemia, endocrine causes, and medications we have in the last question. See, which are highlighted in the yellow: tricyclic antidepressants, atypical antipsychotics, and cocaine. And even this erythropoietin will increase the blood pressure. Erythropoietin and NSAIDs. So we should not prescribe unnecessary NSAID to hypertensive patients. NSAIDs and cyclosporin. We all know cyclosporin increases BP. Then steroids and estrogens. Then whenever we evaluate a patient of resistant hypertension, we have to check his medication list. So they may be taking any herbal supplements. So herbal supplements, this also will cause increase in BP. So most commonly you have to remember is antipsychotics, tricyclic antidepressants, and drugs, which cyclosporin and estrogens. These are the medications causing. So this renal disease we actually discussed. It is more severe in the glomerular disease than in the interstitial diseases like pyelonephritis. So only in glomerulonephritis there will be increased blood pressure. Then this is renal parenchymal cause. Another cause is renovascular. We already discussed renovascular cause can be in older patients due to atherosclerosis, which you have a plaque, which obstructed. Mainly this plaque will be the origin. But in another case is fibromuscular disease. So fibromuscular, it will be renal artery, there will be bleeding, there will be obstruction at multiple levels. In atherosclerosis, obstruction will be only at the origin. So when you will suspect a case of renal vascular hypertension, so whenever a patient has edema, flash pulmonary edema, patient is an old age patient is a decent control, but he has loss of and whenever bruise, renal artery bruise, femoral artery bruise, because the atherosclerosis disease, the atherosclerosis is not renal artery, it occurs in everywhere. Carotid artery, carotid or femoral artery bruise, and integration of renal function. Main important is whenever you do ACE inhibitor, we have to check for creatinine after 3 to 5 days, because whenever it is the patient is having renal artery stenosis, there will be a significant rise in deterioration of renal function whenever it is given with ACE. So only inhibitor, even you have to check creatinine, even if you don't do renal artery Doppler, you have to make the patient to come after 3 to 5 days and check creatinine. Whether up to 10 to 20% is acceptable. Whenever more rise is there, we have to suspect renal artery stenosis. For example, biliary renal artery stenosis, ACE inhibitor is contraindicated. So these are the clinical suspicion for renovascular hypertension. These things we have to suspect when the patient is having this history of all these things. Then which we already discussed is primary aldosteronism. So primary aldosteronism, we all know it is independent of the RAS system. Aldosterone is secreted by a tumor. So excess aldosteronism, it is independent of RAS system. So history and physical examination, there won't be any specific things. Patient will be normal, no obese, no any pointers like Cushing syndrome. Patient will not have any stray and all. So main is we have high index of clinical suspicion. Whenever a young patient is having end organ dysfunction, is having a high BP, hypertensive retinopathy, even if there is no hypokalemia, also we have to think of primary hyperaldosteronism. So moderate to mild hypertension in the young age, this third to fifth decade. So whenever is there, we have to see for plasma aldosterone and plasma renin activity. So whenever the plasma aldosterone is more than 10 and plasma renin activity is less than 1. So at the time we have to, but this 30:1 is highly diagnostic. Even whenever the patient is having plasma aldosterone of more than 10 and plasma renin activity of less than 1, we have to suspect primary aldosteronism and we have to confirm it by further test. Further test like we have to do suppression test, which we will read in endocrine, oral sodium loading, saline infusion test, and fluorocortisone or captopril test. So most important, whenever you suspect, you have to do PAC, PRA, plasma aldosterone concentration and PRA. You have to very specific before ordering this test. You should not, patient should be off spironolactone for 4 to 6 weeks. So whenever you initially diagnose, it's better to plan the patient for this test, because after the patient is taking hypertension, it's difficult to stop and again off spironolactone for 4 to 6 weeks. And you should not having ACE inhibitors, IRB. You should not be having hypokalemia. If there is hypokalemia, you should correct and then take the blood sample. So all these things are should be noted before taking blood samples. So next question, in glucocorticoid remediable hypertension, the chimeric gene is present on which chromosome? So the answer is one of them answer correctly. The answer is chromosome number 8. So what is glucocorticoid? This pathogenesis is very interesting. This is the name itself says you can remedy the hypertension using glucocorticoids. So what happens? We'll discuss this further. It is a rare, it's a autosomal dominant monogenic disorder. It is characterized by moderate to severe hypertension. What happens? Normally, aldosterone is not controlled by ACTH. Aldosterone is controlled by ROS system. But due to the chimeric gene on chromosome 8, there happens ACTH controls cortisol. But due to this chimeric gene, ACTH controlling aldosterone. So ACTH also regulates aldosterone. So at the time what happens? So ACTH will keep aldosterone, leading aldosteronism and hypertension. So what happens when you give cortisol? It is glucocorticoid. So when you give cortisol, remediable, it will inhibit the ACTH. It's a negative feedback. So ACTH won't be secreted much. At that time, the aldosterone will be, ACTH won't stimulate aldosterone. At that time, the patient will get cured of hypertension. So this is the pathogenesis of this GRA, glucocorticoid remediable aldosteronism, which is the mutation on the chromosome 8. The ACTH starts controlling aldosterone. Then the patient aldosterone gets increases and patient is having BP. So the treatment is low dose corticosteroids. Okay. Next is Cushing syndrome. Everyone knows Cushing syndrome. Everyone easily you can diagnose. It is most common is iatrogenic. Most common will be having some herbal medical Ayurveda. In that there will be for pain. In that the patient will have features of Cushing like striae, abdominal striae, diabetes, moon face, buffalo hump. Patient will having some muscle weakness. In that hypertension in Cushing, it occurs to Cushing syndrome. In this, we have physical appearances which suggest for Cushing syndrome. So, any patient we have to see for all these things: striae, proximal myopathy, any steroid intake. So, for this, if you suspect, it's very easy. You have to do 8 AM cortisol. And 8 AM cortisol. If 8 AM cortisol is high, then we have to suspect Cushing syndrome. Then 8 AM cortisol, 24-hour urine cortisol, salivary cortisol. After this, once you suspect, and you have to confirm this further by doing all that low dose dexamethasone suppression test and high dose dexamethasone suppression test, which you will read in endocrine detail. Then treatment can be done. For example, patient is having Cushing's due to any adrenal tumors, you can do surgery, or you can do meterapon, which is a drug which is used to treat Cushing syndrome. Next, coming to the next question, all of the following syndromes are with pheochromocytoma, except, actually, this except is there. So, pheochromocytoma is another rare cause of hypertension. So, all of the following symptoms are associated, except the answer for this question is MEN1. We'll discuss this in the upcoming slide. So this is pheochromocytoma. It is adrenal medullary tumor. Adrenal medulla, it secretes the catecholamines will cause increase in BP. Whenever it's extraordinary, it's called as paraganglionoma. It is a rare cause of hypertension. We say it accounts for hypertension only 0.05%. So some patient will have familial. That only we discussed it. So patient can have MEN2A and MEN2B, not MEN1, because MEN1 we remember the by mnemonic by triple P: parathyroid, pancreas, and pituitary. See, parathyroid, pancreas, and pituitary. Here there is no pheochromocytoma. Then MEN2A, MEN2B, and von Hippel-Lindau. Von Hippel-Lindau, you all know, it will be associated with hemangioblastomas of the cerebellum, all these things. Neurofibroma, Kefeler spots, all that. So all these things are into cytoma. MEN1 is not associated with pheochromocytoma. So whenever a patient has hypertension with classical triad, with headache, palpitation, profound sweat, the patient will have fewer spells sometimes. Patient will have fewer spells. Sweating will be there. So when it is very rare, but when you patient gives these symptoms, then orthostatic hypotension, all these things you suspect pheochromocytoma. So next is coarctation of aorta. This is a cardiovascular cause of hypertension. So it's very important. It is the most common congenital cardiovascular cause of hypertension. When any case of hypertension, so you have to see for radiofemoral delay. So whenever there is radiofemoral delay, you have to suspect coarctation of aorta. So it is incidence is 1 per 8 per 1,000 live births, and it is also associated with syndrome, Turner syndrome. Turner syndrome is also associated with bicuspid aortic wall, coarctation of aorta, aortic aneurysm. During reading of aorta, we'll read about this. So most important thing is, even when you treat the coarctation of aorta, with some stent or the 30% of patients will develop subsequent hypertension or risk of accelerated CAD. This is very important. You have to see for radiofemoral delay and Sussman signs. Sussman sign is a clinical sign. Whenever you make the patient to bend forward, due to the collaterals, you can feel the scapular vessels pulse whenever you make the patient bend forward. So next question: all of the following joints are associated with hypertension. This is a monogenic hypertension. The single gene is associated with hypertension. So all of these are about the monogenic hypertension, as I was telling. So these are single gene associated hypertension. All of the following are associated with hypertension, except this is 21 hydroxylase deficiency. This is associated with congenital adrenal hyperplasia. Actually, this is associated with salt wasting and hypotension, all these things. All other things: 11 beta hydroxylase deficiency, 17 alpha hydroxylase deficiency, and this one, 11 beta hydroxysteroid dehydrogenase. What happens in this thing? So the cortisol has some affinity for mineralocorticoid receptor. So the cortisol is converted into the inactive cortisone by the enzyme 11 beta hydroxylase steroid dehydrogenase. So then cortisone has no affinity for mineralocorticoid receptor. So whenever it is deficient, there will be more cortisol. Cortisol is also acting like aldosterone, so it causes hypertension. So even that licorase, which is used in chewing tobacco, it inhibits these enzymes. So this is called as syndrome of apparent mineralocorticoid excess. Syndrome of apparent mineralocorticoid is not excess; it is apparent corticoid, which is cortisol. Syndrome of apparent mineralocorticoid excess is 11 beta hydroxysteroid dehydrogenase deficiency. So answer for this question is option 1, which is causing congenital adrenal hyperplasia, which is 21 hydroxylase deficiency. All other things cause hypertension. So this we discussed. 11 alpha, 17 less 11 less beta hydrogenase syndrome. Everyone knows it's a ENaC hyperactivation, so causing hypertension. The treatment you know it is amiloride, which you have to inhibit ENaC inhibitor, amiloride, triamcinolone, all these things. So this is the cholesterol metabolism, which is given in Harrison. So the genes involved are 17 beta hydroxylase, 11 beta hydroxylase, 17 alpha hydroxylase, and 11 beta hydroxysteroid dehydrogenase. So all these things which are marked in red causes monogenic hypertension. But 21 alpha hydroxylase, it causes congenital adrenal hyperplasia. So whenever a patient comes with hypertension, you have to do basic investigations: ECG, Then renal parameters, urine albumin, creatinine, GFR, sodium, potassium, so to see for aldosterone, then calcium, then thyroid, hypothyroidism is the cause of hypertension, then basic fasting blood glucose, cholesterol, HDL, and LDL. Then basic investigations, ECG and CBC. Okay. Treatment, everyone knows. First main treatment before medical management is lifestyle modification. Patient should reduce weight, mainly 1 kg weight reduce, systolic people reduce by 1 kg ideal BMI reduce. You have to follow the stop hypertension diet, and you have to limit alcohol intake and do regular aerobic activity. So only this question I have included ACC guidelines because they have asked in the recent initiate 50-year-old male with stage 1 hypertension, ACVD of less than 10, according to ACCHA, which is false. You can answer this question. You can give a try also. Very good. Most of you answer correctly. There is equal participant between option C and option D. We'll discuss. So it's stage 1 hypertension with ACD score of less than 10. So anyway, salt restriction is equal physical activity is common for anything, even it is ACD risk is less than 10 or more than 10. So next confusion is between option 3 and option 4. We'll discuss this question. So this is the AAC guidelines. AAC guidelines, whom to treat. So whom to treat is according to AAC, every stage 2 hypertension we have to treat. In AAC it is stage. In EAC it is grade of hypertension. In AAC stage 2 hypertension, you give BP lowering medication. It is class 1 indication. Then in stage 1 hypertension is same. This 130 to 139, 80 to 21. You have to put ASCVD score. If ASCVD score is more than 10, you have to give BP lowering medication. Whenever it is less than 10, when a BP is patient is stage 1 hypertension, 130 to 139 and 80 to 129, but ASCVD score is less than 10, you have to give non-pharmacological therapy and reassess in 3 to 6 months. But it's more than 10, non-pharmacological therapy and BP lowering medication. So the answer for this question is you should not start pharmacological therapy because ASCVD score is less than 10. If it's more than 10, you have to start pharmacology. You have to reassess after 3 to 6 months. It is according to the ACC guidelines. It's very easy. More than 140, treat. Less than that stage 1 hypertension, see ASCVD. Less than 10, don't treat. Reassess. More than 10, treat. That's all. So this is EAC guidelines. I actually told we'll discuss EAC guidelines. EAC guidelines, it's also very easy. Grade 2 hypertension. That is grading. More than 160, you have to treat. More than 160, see immediate drug treatment in all patients. But in, for example, patients having grade 1 hypertension, it is 140 to 160. You can wait. For example, low risk patients, you can no need. Immediate treatment is only for high risk patients or very high risk patients based on the CVD risk. Any CVD, renal disease are there, or any, for example, patient is having 140 BP, patient is having LVH. At the time, you can start the patient on treatment. Patient is having 140 with some elevated creatinine. Some end organ damage is there in the form of LVH, in the form of elevated serum creatinine, low EGFR. Otherwise, no need to read. This high risk and very high risk. If you want, you can read this one. This is given here, which is this study patient, which is very high risk, which is high risk, and moderate risk, low risk. So from primarily grade 2 hypertension, you treat irrespective of the risk factor. Grade 1 hypertension, you treat only when it's high risk or very high risk. Otherwise, you can wait and you can reassess after 3 to 6 months, and then you can take a call. Okay. So this is the chart from ESC, but now recently ESC 2023 guidelines come, but it has what they are suggesting is, it is not officially published, but what they are suggesting is beta blockers, which is in lower dose, come here. They have put beta blocker at here. You can use beta blockers at any. Primarily, before they told don't use beta blockers, consider beta blockers when indication for use. For example, heart failure, angina, only or post MI, atrial fibrillation, younger woman or who is planning for pregnancy. But this also use along with this. So whenever the BP is high, first we whenever the patient is having whenever the patient is old age and is very frail, then we give only one drugs. Otherwise, you remember this 130, 85. This is the goal. Whenever the systolic BP is more than 20 from this 130 and diastolic BP is more than 10. For example, whenever it is 150 or diastolic 95, you have to start with 2 drugs. Everything we have to combine. Combination is used. Single drugs, there is no use. Single drugs we use whenever the patient is old age, frail, and the patient BP is not more than 20 from 130 and not more than 10 from 85. So whenever the patient BP is around 140, 80, you think the patient you need to treat. And that patient you can treat with single drug. But whenever the patient is having more than 20 systolic from this 130 and diastolic more than 10 from this 85, you have to start with 2 drugs. So 2 drugs combination you see here, ACE or ARB plus CCB or diuretic. Then all 3. Then resistant hypertension, you can add spironolactone or other drugs, alpha blocker, beta blocker. But now recent guidelines, beta blocker has come here. You can add it every step. Okay. Next question. This recent question from Iniset. You can answer. Before you can open the polls. We'll end the polls in 15 seconds due to lack of time. Okay, I'm ending the polls due to lack of time. Sorry. So two of them have answered correctly. It is perindopril plus indapamide. The answer for this question is perindopril plus indapamide. You can't. Patient is BP is more. It's more 160. So forget about single drug combinations. You are doing only double drug combination. Here metoprolol. Patient is diabetic, and the patient is not having any ASCVD risk factor. Is not having any MI angina. And metoprolol also causes hypoglycemic, beta blocker causes hypoglycemic unawareness. It is having some effect on lipid levels. But here it's very true drug. Indapamide, which is a thiazide diuretic, which is having devoid of metabolic side effects. It is devoid of metabolic side effects like hypertriglyceridemia or any alteration in the sugar, devoid of metabolic side effects. So this is you can use. And perindopril. Perindopril, you know, AC inhibitors. AC inhibitor, which is it has no effect on any lipid profile, nothing. So the best combination will be perindopril plus indapamide. Okay, next question. Which drug doesn't have impact on lipid and glycemic control? This is also asked in recent exams. Very good. The answer for this question is prazosin. See, already we discussed beta blockers have impact on lipid and glycemic control. It causes hypoglycemic unawareness. Hydrochlorothiazide is also having effect on lipid levels. It increases triglyceride levels. Prazosin has nil effect. It is neutral effect on lipid levels. So this is anti-hypertensive on lipids. It's very important. You have to know all this. Traditional beta blockers, both cardioselective and non-cardioselective. Products C, atenolol, metoprolol lead to increase in triglycerides and decrease in HDL. And it has little effect on total cholesterol level also. So traditional beta blockers of atenolol, metoprolol, and propranolol leads to increase in triglyceride levels. And also diuretics, thiazide diuretics like hydrochlorothiazide and chlorothiazide. It also high dose whenever you use around 25 milligram of hydrochlorothiazide. Basically, we use 12.5. So it causes 5 to 10% increase in LDL cholesterol also. So all of the drugs are neutral effects. So last option, prazosin is alpha blocker. It is also having neutral effects. So in this thiazide diuretics, indapamide is also having a neutral effect. Doesn't increases any triglycerides or LDL. So answer for this question is last question is prazosin. So which drug acts on TGF beta receptor? This also asked in recent exams. Most of answers spironolactone. Actually, the answer it's on TGF beta receptors. It is option 2, which is angiotensin receptor blocker. So it has specific action on the TGF beta receptor. So only in Marfan syndrome, there is a fibrillin gene mutation. So and it leads to altered TGF beta signaling, which leads to all that aortic root aneurysm, dilatation, all these things. So as in Marfan syndrome, the drug we use are beta blocker and ARB. For example, you can use ARB for treatment of this aneurysms, this thoracic aortic aneurysm, because it acts on TGF beta receptor signaling process, and it can be used for but not clear-cut studies are not there, but they suggest the Alpha ARB can be used in patients with Marfan syndrome due to this TGF beta action. The next device-based, there are some device treatments. For example, carotid baroreceptor. You can stimulate the carotid baroreceptor. When you stimulate the baroreceptor, it inhibits the sympathetic system, so it increases BP and renal denervation. All these are not. It's not giving any promising results. All trials are negative trials. So all this you actually most commonly all these drugs we use. You can remember like this A B C D. B for cardiac. Nowadays they're telling you can use. So A is for ACR ARB and calcium channel blockers or diuretics. A plus CRD first, then A plus C plus D. So in ACR ARB you can use any drug. For example, when the patient is having hyperuricemia, losartan ARB losartan will be useful because it is having uricosuric effect for hyperuricemia. And next, for example, the patient is having diabetes, you can use telmisartan because telmisartan in it's having PPAR gamma action also. So telmisartan in diabetic patient can be used. Other drugs, any drugs you can use, but these are the whenever the patient is having specific indication, you can use telmisartan. Many drugs are there: azilsartan, candesartan. Next, AC inhibitors. So AC inhibitors, you can AC inhibitors also. There is all class effects. It is not any specific drug. You can use many drugs. Perindopril. Perindopril main thing is the AC inhibitor with least cough. Perindopril, enalapril, then ramipril. But this main effect, we'll discuss this. The main effect of this is cough. So AC inhibitor induced cough is it begins within 1 to 2 weeks, most common in females. It resolves once you discontinue the therapy. But if the patient is having troublesome cough, you can change into ARB. Otherwise, it's better to continue AC inhibitor. But especially in patients with heart failure, AC inhibitors has good effect than ARBs. There are some trials with using non-steroidal NSAIDs and aspirin can improve the cough, but it's not used for the cough related to AC inhibitor. There are trials suggesting that improve the cough related to AC inhibitors. This is due to this bradykinin. It's actually a good molecule which causes all these cough things. Next, side effects you all know: hypotension, reduction GFR. Some reduction GFR is acceptable, but whenever bilateral renal stenosis, it can you have to stop this. Then hyperkalemia and pregnancy. Pregnancy, you have to both AC and ARB. You should not give in pregnancy. Next is beta blockers. Beta blockers we already discussed in angina classes. So beta blockers and the most important thing of beta blocker is nebivolol. It's a very good drug. Why we don't use beta blocker before us? Actually, it doesn't. Other beta blockers does not reduce central aortic pressure. But central aortic pressure is very important thing in hypertension. But nebivolol, it reduces central aortic pressure, and it also is nitric oxide. It is a good antihypertension. Nebivolol in the beta blockers for hypertension. Next, everyone knows it is a safest drug and not side effects except troublesome edema whenever you use a doses of 10 milligram. Some edema will be there, side effect, and flushing, headache. And it's another in amlodipine. You can use other novel drugs now like cilnidipine. And now another drug has come which is benidipine. So it's a triple calcium channel inhibitor. Next, diuretics we discussed. Most commonly thiazide diuretics. In this, best drug is indapamide. Alpha blocker we read which is a neutral effect on this one. Prazosin can be used, but the main side effect of prazosin is it causes orthostatic hypotension. So old age patients we should be very careful. It causes orthostatic hypotension. Next, alpha agonist, clonidine, all these things you can use. So this CCBs I told actually it leads to headache, flushing, and dose-dependent peripheral edema. Other things, verapamil lutetium we rarely use for hypertension, but its side effect is constipation. Then resistant hypertension, you should know the definition. Whenever the patient is having a BP 40-90, when the patient is having three drugs of maximum tolerated doses, not any low doses. You should see here best tolerated doses of 3 or more drugs. Among them, one should be a diuretic and one should include a diuretic. This is very important. 3 drugs with optimal doses is not controlled, and the one should be a diuretic. So for this, you have to see the drug compliance, all these things. But the drug of choice for resistant hypertension is spironolactone. Spironolactone 25 mg or 50 mg. So this comes to the end of the hypertension class. Next we'll go to aorta. We'll try to complete fast. Your doubts we'll try to answer in the last. So aorta, there is aortic aneurysm and aortic dissection. It's a largest artery in the body. It has many components: thoracic component and abdominal component. So only we discuss separately thoracic aortic aneurysms and abdominal aortic aneurysms. So thoracic aorta is divided into ascending. This ascending thing is there, arch and descending. So even in ascending there is root and ascending aorta, then arch, then descending aorta, descending thoracic aorta. Then finally your diaphragm is there. From diaphragm we go for abdominal aorta. Abdominal aorta there is all segments. See, suprarenal and in this renal artery there is suprarenal and infrarenal. Suprarenal, this is suprarenal, this is infrarenal. We'll discuss that. See here, this is a beautiful diagram suggesting the ascending aorta. This root, aortic root, sinus of Valsalva, sinotubular junction, aortic arch, descending aorta, then suprarenal, infrarenal. Infrarenal is very important because infrarenal abdominal aortic aneurysms are common. We'll discuss. So what is this aortic aneurysm? So the definition is aortic dilatation should be at least 50% greater than the same aortic segment. It should be increased of more than 50%. 50% should be increased for the same age and sex. For example, this is the aorta. There are two types of aortic aneurysm. One is fusiform. There is fusiform means there is the entire circumference of aorta is enlarged. And for example, this side also enlarged. Whole aortic is enlarged. But in saccular aneurysm, only a part of this is enlarged. This is normal. This entire circumference of the aorta is enlarged. Saccular is only outpouching will be there. So these are the two types of aneurysm. So in we'll discuss separately aortic aneurysm and aneurysms. So abdominal aortic aneurysms are very important. They have less genetic components. Thoracic aortic aneurysms are more related to genetic syndromes, which will be dealing separately. So abdominal aortic aneurysm, you can remember easily abdominal aortic aneurysm. It is atherosclerosis, mainly atherosclerosis. So atherosclerosis occurs in old age. So very important. See, it is dimensions also vary. Abdominal aortic, whenever it is more than 3 centimeter, it is abdominal aortic greater than, it is called abdominal aortic aneurysm. For women and Asian population, the cutoff is less than 3. So these are risk factors. I told you age, older men. First. Second is cigarette smoking. Third is infrarenal aorta, which I discussed previously. Infrarenal aorta. Other risk factors are there: hypertension, hyperlipidemia, and emphysema. But these three are very important: older men, cigarette smoking, infrarenal aorta. So only this, there is a screening also. Whenever a patient is smoking, there is a separate guidelines suggesting you have to screen them for abdominal aortic aneurysm. Like screening for other things like breast cancer, prostate cancer, you have to screen them for aortic aneurysm, abdominal aortic aneurysm. So this is the pathogenesis. Atherosclerosis means inflammation. Same. It is associated with the chronic inflammation, and the proteinases are there. The proteinases which degrade this structural connective tissue proteins, so that integrity is lost. And main thing is the medial degeneration is there. The medial degeneration. This the media gets degenerated, and it will further leads to the dilatation. Dilatation of this. It is inflammation and degradation by this matrix metalloproteinases. So many enzymes are there. So mainly clinical features. It is not. It is very silent. You can't. You can all rarely causes symptoms. So unless there is this is the abdominal aorta. For example, further it is divided into arteries, iliac arteries. For example, here the clot is there and clot gets dislodged, and there is distal thromboembolism and rapid expansion, and only when it's rupture, that the time will be coming to know. Otherwise, it will be silent. So any old age patient, we have to examine their abdomen. We see for any palpable masses. Any palpable abdominal palpation may reveal epigastric or a periumbilical mass will be there. So we have to examine that, and we have to see whether it is pulsatile. Pulsatile mass is there. But it's sometimes it's insensitive in obese patients, but it's better you have to examine this patient so that you can find out the physical examination. Otherwise, also you can we old age patient who smoking is there, some non-specific complaint is there. Better to do USG to see for abdominal aneurysm. Another thing, abdominal aortic, whenever a patient is having other, you're screening for other things, seeing femoral artery aneurysm or popliteal aneurysm, definitely there is high risk of abdominal artery aneurysm. So you have to screen that patient. So major complication is rupture. The patient is stable. So whenever the patient is having abdominal pain and patient is having hypotension, other than all that acute in the to think of the abdominal aortic aneurysm causing bleeding and causing hypotension. So investigations, basic investigation, ultrasound you have to measure. Then important is CT scan is very important. It is important to differentiate the cause, whether it is a inflammatory aortic aneurysm, mycotic aneurysm, or it is a aneurysm due to atherosclerosis. And you can see where is the aneurysm, exact size of the aneurysm, whether there is other aneurysm, for example, involved renal artery aneurysm is there. Each finer details can be seen in the CT scan. For example, this is the renal artery aneurysms. Next, you can, for example, patient, you can plan for pregnancy and all, you can plan for MR angiography. Next, so this I told the guidelines also, there are many guidelines are there. One guidelines I have quoted here, US Preventive Service Task Force, they recommend a one-time ultrasound screening in men 65 to 75 years, same whatever history of smoking, and selective screening for those who never smoked. So this is screening. Next, I told you rupture, it comes in acute hemorrhage, abdominal pain, hypotension due to this, all that blood is coming out. So rupture in the retroperitoneum can lead to the some periatic hematoma and cause severe abdominal back pain. So I have the dissection pain will be there, that may relate to the flank or groin. See, whenever there is a pulsatile mass along with hypotension, you have to suspect aortic aneurysm rupture. Then 30 to 50% of patients ruptured aneurysm whenever the patient is going to dissection, it is very difficult. It is high risk of mortality. 30 to 50% of patients die before the hospitalization, and additional 30 to 40% after reaching the hospital but before treatment. So it is once the patient, so only screening is better. Once the patient comes to dissection, maximum 80% there is mortality. Next, management. For example, asymptomatic aneurysm, when you are screening the patient aneurysm is 5 to 5.5 centimeter, you can plan for repair. Symptomatic aneurysms with rapid growth, you should treat the patient immediately. Requires more urgent consideration. So, for example, I told women there is a less size also for abdominal aneurysm. Whenever they have abdominal aneurysm should be considered for women due to high risk of rupture, even in smaller size. Now you should not wait up to 5 to 5.5 centimeter. For women, there is high risk of rupture, so you have to consider at a younger, smaller sizes, less than 5 centimeter. The two types are there. One is open surgical repair, and second is EVAR. EVAR is endovascular aortic repair. They will put graft and they will close it aneurysm. So endovascular repair and open surgical repair. Next, coming to the other genetic, it's genetically predominant. Aortic aneurysm, which I already discussed. Thoracic aortic it can be anywhere. It can be in the ascending aorta, arch aneurysm, or descending thoracic aorta. But most common is ascending aortic aneurysm. See, this also may ask MCQ. Approximately 60% aortic aneurysms are root aneurysm. This is 60%. Then descending aorta is 35%, and remaining 10% is arch aneurysm. So most important is thoracic, ascending, and root aneurysms are very important. So next, coming to the question, which of the following gene associated with aneurysm osteoarthritis? So the gene associated with aneurysm osteoarthritis syndrome, which is very important, this is SMAD3 gene. So this is SMAD3. We'll discuss this in the upcoming slides. So next, Next question. All of the following genetic syndromes are associated with thoracic aortic aneurysm except. There is mixed answer for this. This also we will discuss. So all these genetic syndromes are associated with thoracic aortic aneurysm except. So the answer for this question is type 1 Ehlers-Danlos, which we'll discuss in the upcoming slides. Next, this you can answer. Which of the following syndrome is associated with this finding in the image? Marfan, Loeys-Dietz, vascular Ehlers-Danlos, Turner syndrome. There is this is also there is mixed response, but this is a classical question. Bifidula. See here, this is the bifidula. Bifidula means Loeys-Dietz syndrome. So answer for this question is Loeys-Dietz syndrome, and genetic syndrome all Loeys-Dietz is associated. 4 is associated, and answer for this question is type 1 and is SMAD3. So this I already this causes mainly is thoracic aortic aneurysm. Same, it is the risk factors like aortic dissection, smoking, hypertension, coronary disease, and family history. Family history is very important for genetic causes. So in this, the pathogenesis is cystic medial degeneration. Cystic medial degeneration is important pathophysiology. It leads to fragmentation of elastic fibers, loss of smooth muscle cells, and increase in deposition of collagen. So the most important thing is cystic medial degeneration. So this is the flow chart. The syndromic hereditary thoracic aneurysmal disease. So most important is all these 3 syndromes: Marfan's, Loeys-Dietz, vascular Ehlers-Danlos. Vascular Ehlers-Danlos is type 4 EDS. So our last option is type 1. So first, Marfan syndrome. It is due to fibrillin 1 gene mutation. This is very important. Marfan syndrome, fibrillin 1 gene mutation. And the most common cardiac is root aneurysm. Root aneurysm, aortic dissection, and mitral valve prolapse. This is very important. In heart, aortic root aneurysm, aortic dissection, mitral valve prolapse. All other things you know. What is the Marfanoid habitus? Thumb sign, wrist sign, myopia, spontaneous pneumothorax, euthanasia. So all this, there is a you read about this modified Jens criteria, and the scoring will be there to tell what Marfan syndrome, modified Jens criteria. So, but cardiac aspect is aortic root aneurysm, aortic dissection, mitral valve prolapse. So, gene is fibrillin gene. Next is Loeys-Dietz syndrome. Loeys-Dietz syndrome, we already discussed. The main thing is bifidula. See, bifidula. Then there will be tortuous arterial tortuosity will be there. Arterial tortuosity. Then I would say thoracic aortic aneurysm, branch vessel aneurysms, MVP. It's very important. All these things will be in Loeys-Dietz syndrome. Another, this SMAD3. This is also given in Harrison. SMAD3 is associated with premature osteoarthritis. So, aneurysm, osteoarthritis syndrome. So, this osteoarthritis syndrome is it's having a very malignant course than Marfan syndrome. So, we'll discuss in the upcoming questions at which is the size to for operative in asymptomatic patients. Next, vascular Ehlers-Danlos, we already know it is collagen mutation, COL3A1. See here, it is very important is uterine rupture. So patient should not undergo pregnancy. If the pregnancy is there, uterus may rupture, bowel rupture, pneumothorax will be there. Things in thoracic aortic aneurysm, abdominal aortic aneurysm, aortic dissection, all these things will be there. Next is all these things. Genes I have mentioned Harrison. If you have time, go through some this ACT2A2 gene is mentioned, MYH11 is mentioned. Main our point of interest is Turner syndrome. So Turner syndrome is actually highlighted bicuspid aortic wall, coarctation of aorta, discussion hypertension, thoracic aortic aneurysm, aortic dissection. So all these things will be Turner syndrome. It is in 1 in 2,500 common disease, 1 in 2,500 live born girls, webbed neck, and premature ovarian failure. So this is the syndrome of aortic aneurysms. So this I already discussed. This abdominal fibrillation leads to the abnormal TGF beta signaling, which contributes to the pathogenesis. So angiotensin TGF beta signaling. So blocking TGF ARBs prevents aortic aneurysm formation. This is done in my studies. So this is extrapolate, and we are using AIS for Marfan syndrome. So this you can see the echo. This is the parasternal lung axis view for the patient of Marfan syndrome. You can see this is the left ventricle leading to aorta. You can see the dilated aortic root. It's very aortic root is very much, and this is the root dilatation. This is normal aortic root dilatation. So this is the parasternal lung axis view showing aortic root dilatation. So this is very important question. This you have read in your PG times also. What is the size threshold for ascending aortic aneurysm repair for patients with Loeys-Dietz syndrome? There is mixed answer. Very good. We'll discuss this question. Okay, the size threshold for ascending with Loeys-Dietz syndrome. So the answer for this question is 4 to 4.5 centimeter. We'll discuss this. See, this is the flow chart given from Braunwald, but this is very important chart. Whenever there is a normal aortic aneurysm, degenerative aneurysm, or bicuspid aortic wall, remember 5.5. So whenever next you go for hereditary thoracic aneurysm, Marfan 5, Loeys-Dietz 4 to 4.5. So this is our answer to this question is 4 to 4.5. Whenever the patient, because I told you, Loeys-Dietz syndrome is malignant course. It is having a risk of aortic disruption, younger, smaller sizes. So it is. Next, Turner syndrome, 2.5 centimeter per meter square. They are given for meter square because child, we have to calculate apparently body surface area. It occurs in the young age. So very easy to remember is degenerative and bicuspid aortic wall 5.5. Marfan 5, Loeys-Dietz 4 to 4.5, Turner 2.5 centimeter per meter square. Then if patient is bicuspid aortic wall, you are planning for aortic wall replacement. Then you can do it as 4.5, requiring aortic wall replacement. Then other two is little bit confusing. This one you remember 5.5 for degenerative and bicuspid aortic wall. Marfan 5, Loeys-Dietz is 4 to 4.5. Turner syndrome 2.5 centimeter per meter square. Then for patient is going aortic wall replacement bicuspid wall 4.5. But these two they are given bicuspid aortic wall with risk factors. What is the risk factors? See here. Family history of aortic dissection, or aorta is growing fast, 0.5 centimeter per year. The patient is having very low surgical risk. Not take risk. You can operate at 5 centimeter. That is the risk. Patient with risk factors like it's growing fast. Patient is having low surgical. At that time, you can operate for 5. Then Marfan with risk factors. So Marfan with risk factors is also given. Same family history of aortic dissection, rapid growth. This is 3 millimeter per year. This is 5 millimeters. This is 3 millimeter per year. Then you have to operate before only. If patient of Marfan, his pregnancy is desired, you should prepare 4 to 4.5. Like Loeys-Dietz. You have to operate at 4 to 4.5. With other risk factors, more than 4.5. You can go through this flow chart once again so that you will be thorough with this. So other causes are there: aortic dissection, homogeneous diverticulum, syphilis, and degenerative causes. So what is homogeneous diverticulum? Homogeneous diverticulum is aberrant takeoff of left subclavian right subclavian from left carotid from right carotid from left. So the answer for this question is aberrant takeoff of right subclavian artery from the left. See, this is the answer for this question, right subclavian artery. You can see here the aberrant right subclavian artery is there. This is the right subclavian artery, but it is arising from the left side. It is arising from the proximal descending thoracic aorta. This is called as aberrant right subclavian from left side. But whenever it is dilated, it is called homogeneous diverticulum. So aberrant right subclavian arising from descending aorta, and it goes to the contralateral upper extremities. So whenever it is dilated, this aberrant artery is dilated. This is for other cause of aneurysm. So it can cause aneurysm, can cause dilatation, cause FVC syndrome. It can obstruct the major sections of voice. Can cause back pain, chest pain due to the muscle, and it can erode the bones. So this X-ray, you can see the X-ray. You can see the descending thoracic aorta hugely dilated. So treatment same for thoracic aortic aneurysm. You can do same open surgical repair or this is endovascular repair, endovascular aortic repair, and then modified Bentall's procedure. This is surgical procedure which they done for the treatment of thoracic aortic aneurysm. Next, coming to the aortic syndromes, most important is aortic dissection. All other things, aortic rupture is there, aortic dissection is there, intramural hematoma. What happens? This is the aorta. In aorta, there can be rupture vessel. The blood vessel supplying the vessel is vasa vasarum, which supplies the blood vessel. The blood vessel is supplying the blood vessel. When it ruptures, it causes intramural hematoma. Rupture of vasa is the pathogenesis. So this next question: which of the following DeBakey classification does the image represent? So which of the following DeBakey classification that this image represents? This is only ascending aortic orientation. So the answer for this question is the answer for the question is DeBakey 2. We'll discuss this in the further classification. See, you can remember easily. Stanford classification is type A, type B. A is only ascending, not only ascending, it is involves ascending. Stanford A is ascending, B no ascending. So A is for A for ascending. See here, this is Stanford A. It involves ascending and descending and only ascending. Stanford B is not ascending. So same as for DeBakey. DeBakey type 1 is whole ascending aorta, arch and fully. But DeBakey type 2 is only ascending aorta involved. DeBakey type 3 is only descending aorta involved. So I have given the flowchart here. See here, DeBakey 1 ascending aortic aorta fully. DeBakey 2 only ascending aorta. DeBakey 3 only the descending aorta. Stanford A ascending aorta, Stanford B not involved ascending aorta. Okay. So all of the following conditions risk factor for aortic dissection except. This is our question. All of the following conditions are risk factor for aortic dissection except. Very good. There is equal answer for all the 4 questions. We'll discuss this. So all of the following risk factors already discussed about this deeds which cause aortic aneurysm. We discussed about this. Turner, you can rule out this tetralogy of aortic dissection. So answer for this Down syndrome. See, these are the risk factors. Already we discussed all these 4 things. Marfan, Loeyd's, vascular adenose. The non-syndromic, all that ACT2 mutations, all that I told you. Then congenital conditions like bicuspid aortic wall, coarctation of Turner, tetralogy of Fallot. Then main hypertension. All these things is sophisticated. Hypertension, you should not forget. Hypertension is the most common cause of hypertension. All these are inflammatory, IgG4. Then this is your underlying aorta is there. This is the so clinical. So you can main same aortic main is having strain. For example, the patient constipation straining at stool in the rupture, sudden onset of pain, which is very severe and tearing, and is diaphoresis. So it is a type of pain, descent back pain. So physical tension, hypotension, loss of very important. When our patient comes with chest pain, you have to see for pulses. Equal pulses are there. That side there will be no pulse. Aortic regurgitation due to ascending aorta. Due to other finding, neurological finding, due to wherever it obstructs, it can cause. So this presentation, it's dependent upon intimal tear. Second thing is dissecting hematoma and occlusion of the involved arteries. For example, this is the aorta and this is the renal artery. Then the aorta is dissected. Now aorta dissected is flap is coming like this. So it is obstruct the renal arteries. And it can lead to renal failure. So it can obstruct the mesenteric arteries, lead to bodies. So this is the organ mixed manifestations. Very important. This we'll discuss about the cardiovascular only. Aortic regurgitation can occur. For example, this is the ascending thoracic aorta. Here the dissection is occurred here. So it leads to in coaptation of this aortic leaflets, leading to regurgitation due to the heart failure. Then coronary ischemia due to obstruction of coronary arteries. Then it can rupture and into the pericardium, into cardiac tamponade. It can rupture anywhere, pleural effusion. I told you already, renal ischemia, renal failure. Very important is stroke. Whenever the patient is having stroke, it's a very deadly prognosis. It can affect stroke, paralysis, paraparesis, and coma and ischemic neuropathy. One patient with IPA dissection recently presented with stroke in our ICU, but he recently died also. It's very IIT dissection is a big three of cardiology: IIT dissection, pulmonary embolism, and MI. So very high mortality is there. Next, mesenteric ischemia is there. Wherever it goes, it simple. So investigation you have to do mainly first is TTE you can do. TTE you can do for ascending aortic aneurysms, all that, and the arch, all that. But whenever it is other than the descending thoracic aortic aneurysm, you can't see abdominal aortic aneurysms. At the time you can plan for CT aortography, MR aortography. TE also gives a better visualization of the dissection. So main treatment is anti-impulse therapy. Anti-impulse therapy is there. So here we reduce the BP, reduce the heart rate. Goal is less than 120. Even if the patient is having BP of 130, you have to reduce the BP 120 and heart rate less than 60. So main rate is reduce cardiac contractility and reduce systemic arterial pressure by mainly beta blockers. You can use beta blocker, IV labetalol, esmolol, sodium nitroprusside, nitroglycerin. All these drugs you can use to reduce the BP. So main thing is type A. Type A means type A it is surgery, emergency surgery. Emergency surgical reduction is preferred treatment for ascending aortic aneurysm of type A. But type B, actually, it is there are some indications. Type B, it's mainly medical management. We can reduce the BP and reduce the pulse to prevent the extension of dissection. So mainly you use that TEVAR only in this indication. So I have mentioned the specific indication here. So these are the indications. All other not every case you go and do surgery or you implant a graft. So these are the indications for that is TEVAR, thoracic endovascular aortic repair, for only complicated cases. For example, patient is having impending rupture and patient is having some ischemia, renal ischemia, then hemothorax, then all this refractory pain, refractory hypertension, and so much dilatation, unreasonable dilatation more than 55 millimeter, rapid increase in aortic diameter. Same, this indication fits for aortic aneurysm also, and recurrent symptoms. So whenever the patient is having any perfusion or rupture or anything is refractory hypertension, recurrent symptoms, and aortic diameter. So all these things are the indication for TAVR in type B aortic disease. Otherwise, you can manage them with medical. Okay, this comes to the end of the class. Thank you so much. In clinical practice, you can follow any guidelines whichever is comfortable. I have discussed ESC guidelines. Mainly that indapamide, I told only it is mainly that metabolic side effect is that lipid profile. It doesn't adhere the lipid profile much. But hyponatremia, it's also said that it causes hyponatremia. I am not very sure about that. But indapamide is neutral on lipids. It don't causes any hypertriglyceridemia or increased LDL. Any other questions are there? Yes. Okay, thank you so much.